affects thousands of people every day across the world. Our individual lifetime risk of fatal or non-fatal myocardial infarction is around 1 in 10. And for those that survive, myocardial infarction can have a substantial impact on future health, well-being, and even livelihood. Fortunately, the treatment's effective, highly effective, and improves survival if given early. But the effectiveness of treatment differs depending on the underlying etiology and the setting in which myocardial infarction occurs. Why do we need another international consensus? Stefan's been diagnosing heart attacks for 35 years. Well, standardizing the diagnostic criteria for myocardial infarction is important for research, for our clinical trials, and for our practice, so that the findings from our scientific meetings can be directly applied in our patients when we return home. Consensus helps to promote the use of evidence-based approaches to diagnostic testing. It helps us to identify and address inequalities in diagnosis and care. And it helps us to recognize where there's uncertainty and highlight research that's required to try and reduce that uncertainty in our practice. But of course, the ultimate goal is, and we're going to need your help with this, is to improve outcomes for people with acute myocardial infarction through precise and timely diagnosis. So the 5th Universal Definition of Myocardial Infarction is actually the first joint statement from the European Society of Cardiology, the American College of Cardiology, the American Heart Association, and the World Heart Federation in any area of our practice. It was developed by a multidisciplinary task force with representation from 12 countries across 5 continents. We had excellent external independent review from an 18-member committee, including patients with lived experience of heart attack. I'm also delighted that it's been endorsed by cardiac, surgical, and interventional colleagues across the world. So the diagnosis of myocardial infarction has evolved considerably since it was first recognized by pathologists in the 1890s. Consensus has been needed for the clinical diagnosis, the introduction of electrocardiogram, the first biomarker, and more recently, the introduction of everybody's favorite test, cardiac troponin, and in particular, high-sensitivity assays. Since the turn of the century, we've had 5 iterations, which I think reflects the remarkable progress that we've made in our understanding of this condition. Now, multiple classifications have been proposed. Arguably the most successful and widely adopted has been the simplest, and that's the clinical classification of STEMI or non-STEMI. Why? Because it has direct implications for patient care. But whilst it's simple, it provides little or no insights into the underlying cause of myocardial infarction that influences treatment long term. Now, whilst in many the diagnosis is straightforward, the challenge is that lots of people don't describe or experience classical symptoms. Most of the electrocardiogram is unhelpful. There are no definitive diagnostic changes, and actually the majority, the working diagnosis of myocardial infarction is suggested by cardiac troponin. Now today, cardiac troponin is measured very widely across a range of acute care settings. And over the last 10 years, we've understood that acute and chronic myocardial injury is common in a wide range of medical conditions. And indeed, it's nearly ubiquitous following most of our cardiac procedures. As a consequence, the current classification has been challenging in places to adopt. So the objective of the task force was to provide an updated, evidence-based definition and classification of myocardial infarction to support consistent diagnosis in our practice and research across the world. So what's new? Well, the criteria for a clinical or working diagnosis are essentially unchanged. And the diagnosis requires evidence of acute myocardial injury and symptoms or signs of myocardial ischemia. However, the new definition recognizes that coronary imaging is required to define the etiology, and imaging is necessary to confirm or exclude the diagnosis of myocardial infarction in some settings where the diagnosis is particularly challenging. The criteria for acute myocardial injury have been refined, and the underlying mechanisms extensively discussed. 6 specific upper reference limits define both acute and chronic myocardial injury. This is important. It avoids systematic bias in our care and the under-recognition of both myocardial infarction and chronic structural heart diseases associated with myocardial injury in women who have consistently lower cardiac troponin levels than men. Building on previous approaches, the 5th Universal Definition introduces a new classification. It is based on the underlying pathophysiology. It is aligned with the way that we evaluate patients in our clinical practice, and is supported by objective diagnostic criteria. It's designed to be easy to apply in practice, to be readily understandable by patients, their relatives, and non-expert clinicians, and to ensure that the diagnosis of myocardial infarction always directly informs management and care. The previous numerical classification has been replaced. Myocardial infarction is now classified into one of 3 clinical types: primary, secondary, and procedure-related. Primary myocardial infarction incorporates all spontaneous presentations due to a primary acute coronary pathology. Secondary myocardial infarction is restricted to those presenting with an alternative acute condition where supply-demand imbalance unmasks obstructive coronary disease, or the extent of myocardial injury results in new left ventricular impairment. And procedure-related myocardial infarction is recognized where a complication causing an immediate coronary or graft occlusion results in new left ventricular impairment, or our coronary revascularization fails within 30 days of the procedure. So for the first time, ICD-11 codes have been co-designed with the World Health Organization within this framework. And this will enable us to clearly recognize all etiologies of myocardial infarction. That will help us support implementation in practice. I'm now going to hand over to my co-chair, who will tell you more about the diagnostic classification.